working?
Yeah.
Well, we don't even need it. First of all, welcome and good evening. We're a very small group, it's very informal tonight, and I hope that's what we will be. And I want to welcome all of you to the public library. I hope that if you don't have a card, we hope by the time you get through tonight, you want to walk around and see the library. We hope you will get a card. I'm privileged to moderate our discussion tonight, and this event is sponsored by the library board. We're fortunate this time because we're partnering with both hospitals, with St. Mary's and Memorial, and it's really the first of a series of community lectures that forums, whatever you want to call them, that we want to do in the community. I think there's a need for it. I think if the weather was better and a little warmer, we probably had another 50 people here because of the topic. I'm one of the trustees at the library. The executive director, Michelle, is here tonight. I hope you get a chance to meet her. If anybody doesn't feel well, we have some doctors in the group that take care of you while you're here. The topic that we're talking about, of course, is not only important to the community, the country, but the world. Ebola. And we're lucky because we have tonight 3 of the most informed people on the subject that you could find in Western New York. They're right here at our disposal. We're talking about the 3 doctors, Dr. Bajwa, Dr. Cumbo, and of course Elaine Roman, the Health Department. They're one of our sponsors too. Our plan is that each one will have an opportunity. I think 2 of the people have PowerPoints, and Dr. Cumbo, he'll just make it up if he doesn't know it, so he'll talk to you here too. Our intention is that when they get through their presentations, and if you have any questions or any comments, we hope you have a chance to hear from the experts on them. And we'll conclude by 7:30. Even though the library, there's 3 other things going on at the library tonight. We have the jewelry making class across the way, and the local history department upstairs. I think we have a poet storytelling program going on at the same time. So the building is busy tonight, and we're glad you're here for this particular one. Our first presenter is Dr. Rajinder Bajwa. Dr. Bajwa is an infectious disease doctor at Memorial Medical Center. He's a graduate of the medical school, and you have to tell me how to pronounce it.
Punjab, India.
India. He completed an infectious disease fellowship at the University of Buffalo and Buffalo VA Medical Center. Dr. Bajwa is board certified in internal medicine and infectious disease and holds professional memberships in the American College of Physicians, Infectious Disease Society of America, and the American Society for Microbiology, and the Medical Council of the whole country of India. You got your work cut out for you.
Yes, MC, American Council of
In the meantime, why don't we welcome Dr. Bajwa, and he will go on first, and then we'll be followed by Dr. Cumbo, and then Elaine will follow up after that.
Thank you so much for inviting me, and I hope I'm going to share this information about Ebola, which is like everybody is talking about it, so we should have accurate knowledge about this rather than relying on hearsay. So thank you for giving me the opportunity. So I'm going to talk about the disease itself, and my topic of discussion, I'm going to keep it restricted to how how this disease is, we're going to get this disease, and what things we can do to prevent the spread of this disease. And then Dr. Cumbo is going to talk about what our hospitals are doing to meet the requirements put in by the health department to prevent the spread of this disease. And Elaine Roman, she's going to talk about the public health aspect of this disease. So Ebola, so the story started in 1976. The first slide.
Down arrow.
I am, trust me.
I have a lot of doctors here. They probably can fix it. They're very good with the technology.
anyways, the first case reported was in 1976 in Western Africa's countries of which Zaire, now called the Democratic Republic of Congo, in 1976. So in September of that year, there were around 316 reported cases of viral hemorrhagic fever. So there was a viral disease which was causing temperature, which is fever, and the persons affected, they were bleeding. They showed signs of bleeding at different sites. And till that time, this virus was never reported before. And this outbreak lasted for a couple of months. Investigations later found out that this is a new virus which was discovered, and they named it Ebola virus. So it is it's working. Next one. Yeah, next slide. So technically, this is a RNA virus. So there are two genetic components of any infectious agent. One is DNA or RNA. So this particular virus belongs to RNA family, and the family is a filoviridae. Philo means filamentous. This virus looks like a filament. That's why they call this family as a filovirus. And there are 5 different kinds of this virus. Why this is important? They differ in the virulence. Virulence means when a germ causes infection, how severe infection could be. So based on that, there are 5 different varieties. The Ebola virus, which is Zaire Ebola virus, the present outbreak is attributed to this virus, causes mortality up to 88%. Then others are Sudan virus, Ivory Coast virus, Bendigo virus, and Reston virus. The last one, Reston virus, never has caused disease in humans.
Are they listed in highest to the lowest virulence?
Like Ebola virus or Zaire, yes. So it causes it causes maximum mortality known to us.
So that's
up to
highest to
88%. Yeah. So the Sudan virus is a 50% case fatality rate, and the third one, the Ivory Coast virus, there is only one documented case, and that was of a scientist who was working with the primates in Ivory Coast. And Bendigo virus is 30% case fatality, means 30% people, they are going to die if they acquire this virus. And the Reston virus does not cause human infections. It causes infection in animals.
Yet.
Next slide, please. So since 1976, this virus has caused a sporadic infection. So there are 3 things which I want you to look at. So look at the years where they have caused. So it's not like it's a perpetuating, like it's the infections, they happen for a few months, then they go out of the community. And most of these infections, up till the present one, they have been in the African nation. And most of them, they have been in sub-Saharan Go back.
Is it my glasses bad or is that blurry? That's what I thought.
So most of these have been in sub-Saharan Africa. All of the previous 23 outbreaks. And if we look at the deaths, they have been always in few hundreds, never reached thousands, which has happened this time. Next slide. So till November 14, this is a statistic from World Health Organization. So 8 countries have been affected with this virus outbreak, and 3 of them, Guinea, Liberia, Sierra Leone, they account for most of the disease which has been seen in up till now. There have been around 14,000 cases with 5,000 odd deaths, and in the United States, next slide, we had so far 4 cases. So we only count for cases which are diagnosed within the United States. We do not count for cases which were acquired and diagnosed in Western African countries and brought here for treatment. So we have 4 cases which were been diagnosed. The first one was a Liberian man who died of the disease, and 2 healthcare workers who took care of that index patient who acquired the disease. Both of those healthcare workers, they are released, they are safe, and they are cured from this disease. And the 4th one was recently diagnosed in New York City. He's a physician who returned from Kenya, I believe, and was diagnosed. He did not have any symptom when he came home. So in the United States, he developed the symptoms and later was found out to be Ebola. He's also cured from this disease. And overall, we have taken care of 10 patients so far in the United States, 2 deaths, 8 survival. So as we have seen in the second slide, so this virus is not like active in the humans all the time. So it comes and it goes. So when it is not in humans, where does this virus stay? We do not have accurate answers, but there are some epidemiological data which suggest that fruit-eating bats in those regions, they act as a reservoir. Means the virus can live in those bats without causing disease. That's how this virus is perpetuated. Next slide. So, so this virus is probably in the bat, in the fruit-eating bats, and somehow this virus spills into the primates or into the humans when the outbreak starts. So eating bushmeat is one of the risk factor, and handling these animals is the risk factor for getting this disease into the humans.
Is it accurate to say that it started as an animal virus and then it jumped onto human beings?
So, let me put it this way. So this virus has been there. We do not know how long this virus has been there. So what happens is, as long as this virus is in its reservoir is anything where the organism can multiply without causing disease. And then it spills into a different organisms, say primates, chimpanzees, gorillas. So once it goes there, it causes disease. And
so how does it get from the reservoir into the primates?
we do not know exactly.
We don't know that. Okay.
Yeah, but certain habits like eating bushmeat. Bushmeat is basically eating like non-domesticated animals for meat.
Do
Like
the primates eat those meats?
humans do definitely eat the fruit bats.
Okay.
And they also eat the other animals which die of this disease. And when they are handling those animals, because the blood and the body secretions of these infected animals, they have a lot of virus, and that's how, that's all like what we know.
That's all we speculate.
Yeah. So once, next slide. Once the virus comes to human, that's the point when the outbreak, the chances of outbreak are there. So this virus, once in humans, can spread from human to human if there is a direct contact with the blood or the body fluids of a person infected and sick with the symptoms, or objects which have been contaminated with virus. Ebola is not spread through air or by water, and the mosquito bites and other animal insect bites are not known to transfer this disease. So the kind of exposure which can lead to this infection is if somebody is stuck with needle or splashed in eyes, nose or mouth with blood or body fluids with someone sick with Ebola. So this is important. Someone who is showing symptoms, like a person who is sick with the disease. If somebody handles blood or body fluids of a sick Ebola patient, touch a person who is sick, care or live with a person who is sick with Ebola, touching the body of a person who has died from Ebola, or spending a long amount of time within 3 feet. This is considered a close contact. And it has to be prolonged with the person who is sick. So the emphasis on the sick person. So asymptomatic patient person does not have is not known to be infectious. Do you have questions?
Now, 3 feet,
Yes.
is it an airborne
Yes.
or
No, it is not airborne. It's not like if I'm
Droplets.
talking, it is not like a tuberculosis that is going to travel through air and someone sitting next to me is going to get infection. It's only when like if my saliva, like when I can like spit. If I'm vomiting, if I'm having symptoms like I vomit on somebody, if I'm sick with Ebola, I vomit on somebody. So that's how it happens.
so
It's
the
not like
transmission is only through transfer of fluids?
transfer of fluids. If my saliva or spit it falls into the mucous membrane, like eyes, nose, or mouth, or open skin sore, yes, there is chance of transmission. It's not like just casual contact. So what, like, do we have any objective evidence to show that what we have said is right or not? So there have been some studies which have been done, like how this virus is transmitted. And I picked up this study. This is a study published in Journal of Infectious Disease in 1999, and they looked at outbreak in Democratic Republic of Congo in 1995. And in this is an epidemiological study. Epidemiological study is basically when the healthcare personnel, they go and interview the contacts and the patients. So they try to trace back 173 contacts who were living with the diagnosed patients of Ebola in the same household. So there were 27 patients, 27 different households with 173 contacts living within that household. So the results of this study shows this. Next one. So out of 173 people who were living with these diagnosed cases of Ebola, 27 diagnosed patients of Ebola, only 28 got this disease. So that puts it 16%. And they were living with the family. They were not using any kind of precautions which we will use in our hospitals if we are treating for Ebola patient. And of these 78 contacts, they do not report any physical contact, and none of them they showed signs of or disease, like they got infected. And among the different kind of contacts, the risk was like the highest if they touched the blood of the patient. So based on this study and other studies, so the risk of transmission is highest if somebody comes in contact with blood, feces, or vomit. So these are the 3 fluids which are highly infectious. So the virus has been detected in other body fluids, but we do not exactly know how infectious or how what's the risk of transmitting infection from other body fluids. And the quantity of virus in the fluid is important. So if I get infected with the virus today, I probably do not have enough viral load, like how much virus is in my body to transmit it to someone else. But as the disease progresses, like day 3, 4, 5, or when the patient starts showing symptoms, the viral load goes up and chance of infectivity goes up. And the most infectious would be a dead person. Like dead person has like millions of viral in a few mLs of blood. So that is the most infectious stage. You had a question, Dr. Chandra?
The statement here says there is 16%.
16. So 60, like out of.
Is that meaning people who did not take any precautions?
Yes.
Only 16 out of 100
got
got
this
infected.
disease. And
So it means it's not very infective.
yeah, that's the point I'm trying to make. Like if we take all the precautions.
Yeah. So if you take all the precautions, the
this going to
infectivity
be
is very
low.
low.
Yeah.
Okay.
Dr. Cumbo, why don't you jump right in?
Sure. Well, I just wanted to ask you, in this paper, this was people in all stages of the disease as well.
Yes, this
So
was.
it's not just the recently
Okay.
infected people. These are people that were quite ill too at the time. And it's still, the transmission rate is still
Yeah.
16%.
Just so you know, Dr. Cumbo is going to be talking next, and he's the infection control doctor at St. Mary's.
Yeah,
And they're-
we never seen.
Yeah.
Work together.
Okay, so next slide, please.
I'm sorry, I'm having some trouble moving
That's
the
okay.
slide, so we're
So,
working on it here.
so the risk is more as the patient goes, as the patient becomes symptomatic, and worst when the patient dies of this disease. So that patient will have a maximum virus, and that is the time when you are going to get infected. And there is some risk of transmission through contaminated surface. Like if somebody is sitting, a patient who is sick, vomits on something, touches something. So there is a theoretical risk of acquiring infection if I touch that surface. But what the risk is we do not know exactly how much is it. So airborne route. So Dr. Shannon raised the question whether this is airborne. So, it is not an airborne disease, but what we do in hospitals is something different. Like we use more invasive procedures where sometimes the secretions of those patients, they are aerosolized. It means we do procedures which make those secretions float in air like particles. And that's the time it may be, we do not exactly know, but it could be one potential area where we can inhale and get the virus. That's why more rigorous precautions when we are taking care of these patients in the hospital, and Dr. Cumbo will tell us what our hospitals are doing about preventing our healthcare workers from getting.
Like Dr. Cumbo was saying, these patients were very, very sick, and yet you only had less than 20% of the contact person getting sick. What happened since 1999 to 2014?
Yes.
That
So
all of a sudden
it's a very valid question, and I am going to address that question in the coming slides, because this is the question. This is, and I will come back to that question later on in my presentation. So next, so once the virus is inside, it can directly affect the organs like liver and other vital organs. So there is a direct damage. This virus destroys the blood cells, especially the platelets, which prevent bleeding, and it damages the blood vessels. So blood vessels leak fluid out into the body. So these patients, they get depleted of fluid. They have low blood pressures. They hemorrhage or bleed. Next slide. So the symptoms of this disease are over 90% of patients, almost everybody, I should say, will present with the high-grade fever. Other symptoms will include severe headache, muscle pain, weakness, diarrhea, vomiting. These are all non-specific. So there are no symptoms which will suggest that this is Ebola. So any viral illness can present like this. And there are multiple lab abnormalities. The blood cell count can go down. There are electrolyte abnormalities. So this is more technical. I'm going to skip this slide. So prevention is the key. So, there is no FDA-approved vaccine available as of yet for Ebola. So if we come in, if we know that somebody has Ebola, so we have to use protective clothing, including mask, glove, gown, eye protection. Washing hand with soap and water is good. It will kill this virus. And if we use the alcohol-based rubs, that is equally effective. And inanimate surfaces could be cleaned with the bleach wipes. We should always be alert. So that is the most important thing. Conscious of your surroundings. See if there is somebody who has come to the community, who has traveled to these countries. And depend upon reliable sources. Don't go over the hearsay. So New York Health Department website is very good. I was going through that last evening. And CDC website, World Health Organization websites, they are excellent sources. So this is a busy slide, but the only thing which I would like you guys to concentrate is on the no-risk category. So the person who comes in contact with person who had Ebola but is not symptomatic, that is no risk. A contact with person of Ebola before person develops symptoms, that also puts you in a no-risk category. Having been to a country where there has been outbreak and 21 days have elapsed without symptoms, that is also no risk. And any crew member or ship member who travels to these countries but they do not actually mingle with the local personnel, they are also at no risk. And having been to a country where Ebola is not widespread, like United States, for example, like we have diagnosed few cases, but we are not widespread. So coming to US and then going to a different country does not pose any risk. So this is a no risk category. And then there are high risk, some risk, and low risk. The only thing is in some risk category, so any healthcare personnel who has gone and treated these patients in the countries where there is actual outbreak wearing the personal protective equipment, they are put into some risk category. And the healthcare personnel in the United States who cared for these diagnosed Ebola cases, they are put into a low risk category. Why risk stratification is important? Next slide. So if based on these risk categories, we see that if they are high or some risk, so there is an active monitoring. Monitoring is, so active monitoring is basically if I tells you or someone to take your temperature 2 times a day and look for these symptoms and call me if you have a temperature or symptoms. That is active. But then there is a term called direct active. Indirect active is basically health department will get in touch with that person and actually ask what is the temperature, do you have these symptoms. That is direct active. So anybody in the category of high or some risk will be actively and directly monitored by the health department. And if they fall in low risk category, they are actively monitored, except for healthcare personnel or a person who traveled with in a plane where there was a diagnosed case of Ebola and he was seated within 3 feet of that diagnosed case. So those 2 exceptions for low risk who will be directly actively monitored. And if there is no risk, there are no restrictions and they need not be monitored at all. And this is for asymptomatic patients. And if they have any symptoms, they should be evaluated and tested for Ebola before they are let free. Next slide, please. And there are, what kind of tests we have? So we have to send blood for a PCR testing where they are actually detecting the viral genome or the genetic material of virus in the blood. And not all the labs, they are permitted to do this test. Only the state lab at Wexford probably, is that correct? Our state lab is at Wexford?
Yes.
Yeah. So the blood has to be sent to that lab and they will run these PCR tests. The only, there's a chance of missing this disease if we do PCR very early in the stage of disease. So say a person who traveled to these affected countries and had a contact 2 days ago. So they might not have enough virus to be detected with these machines. So we have, if we suspect that the patient had a contact, we have to repeat PCR test, this test in 2 days, just to make sure that this is not just a false negative test. So treatment, there is no treatment approved by FDA for this disease. So everything which we do in the hospitals is basically supportive care. These patients, they have low blood pressure. We try to maintain their blood pressure by giving them more fluids. They have tons of mineral or electrolyte abnormalities. We try to correct that. If they get super infection, like they get a bacterial infection on top of it, we will treat that. And then there are experimental drugs like ZMapp, use of whole blood or serum from a patient who has recovered from this disease. Then there are a drug called brincidofovir which has been used, and then there are RNA interference agents.
I don't know if you know, this new guy from surgeon who just died, Sierra Leone, he had a test which was negative, which they are saying is false negative. Is that the same thing what you are talking about, or?
I'm not 100%
may
sure,
not
but
be able to.
definitely we can miss. That's why I brought up that point. Like if somebody has a PCR test very early stages, they do not show symptoms, it could be negative. So if there is a strong history or high risk of exposure, I would repeat that test in 2 days just to make
2 days is enough?
The incubation period for this disease is 2 to 21 days. Incubation period is basically when someone gets the germ and shows the symptoms. So this, if I get this germ today, so I can show symptoms up to 21 days, and 2 days is the earliest I can show. So if I do not, if I check my blood, on day 1, it could be negative. If I check in day 2, it still could be negative because incubation period could be up to 21 days.
So suppose you do on day 1 and then you do on day 4 and it is negative. Do we need to redo after 2 days, or
Symptoms.
we
you
wait
show
for the
symptoms.
symptoms?
Based on the symptoms.
You
have to
have
show
to wait for symptoms.
Wait for symptoms.
Yeah.
Okay.
But you can do at least 48 hours apart.
Okay.
That's what is recommended.
Okay.
So when to discharge these patients, once they are symptom free, we have to check their PCR for virus and repeat it in 48 hours. If both PCRs are negative, these patients, they are free to go back into the community. So now I'm going to talk about the current outbreak, and I will try to address Dr. Bajwa's question. What is different in this virus? So the initial case reports, initial cases were in Guinea, West African country, and they were in December 2013 to January 2014. Cases occurred in one family, and from that family, the cases from January to March 2014, they went to the other family members and then into the healthcare workers. And in March of 14th March, that was the first time WHO, World Health Organization, was notified about this disease outbreak in Guinea. And it wasn't up till August 8th, I should say, that the WHO declared it as a public health emergency of international concern. So it took 5 more months before WHO declared it a public health emergency of international concern.
Dr. Bajwa, if any other people have questions, I probably should change. We won't do it at the end of the meeting. If you have questions on the slides up here, like Dr. Shannon and Dr. Bajwa, please just ask. Don't wait for after the meeting, because you might forget what they said before. You might get interrupted, and I don't think either doctor would mind that.
Yeah, no, I'm fine with this. So what is different with this current outbreak? Because we have seen this virus has never traveled out of Africa up till now, and there were only a few hundred cases at the most, and it will last for a few months and then die off. Whether this is a different virus or something else has changed. So to address that specific question, there is the first one. So there is a study published in last month's New England Journal of Medical Journal, so which tried to answer this particular question, and they reviewed 4,000 cases, out of which 3,300 were confirmed cases and 700 were probable Ebola cases. And what they found out was the clinical course of infection and transmissibility of this virus was similar to previously reported Ebola virus outbreak. So there was no difference. The incubation period, duration of illness, case fatality rate are all within the ranges which have been previously reported. And the combination of signs and symptoms recorded between symptom onset and clinical presentation is also same. So there is no like major difference so far, whether this is a new virus. They have done studies. There could be some difference, but this is not a new virus. So what has changed is probably the attributes of affected population, and international efforts have been probably delayed.
Dr. Bajwa, with all these 1,000 soldiers they sent overseas,
Nobody got infected.
what's the possibility that they will get infected?
So, like if we are going to treat or come in active contact with patients where outbreak is actively going on, there is always a risk, okay? But how, if you are going to take all the precautions, going to wear all the like standard procedure, protective equipment, chances are very less. But they are still at some risk category. It's not absolutely no risk. So there is some risk, definitely. But to quantify how many will get, that is unless Dr. Cumbo has.
To my
specified.
knowledge, these soldiers were only involved in setting up the camps. They were not actually involved with the patient care, right?
That's my understanding.
So there is no chance of them.
Yeah, if
They came back and they were quarantined for 21 days, nobody had it.
if they are not going to,
No, I wanted to say something here. The guy who died in Dallas, Mr. Duncan, he lived at home
yeah,
and was exposed, how many in the whole family? I don't know, 17 or 18 people.
Nobody got it.
Nobody got it.
nobody got it. Yeah.
So it's the transmission is not that easy.
That's what, like, even the studies show
And
that.
they were all in the same house, in the same apartment, all those people.
I have a question. A lot of people are scared because it has such a high fatality rate. But how do they figure that? Because quite honestly, it's unfortunate. The only outbreaks have been in countries where they don't have proper medical, if they become sick and they don't have all the supportive care right at their disposal like we would have in the United States. So isn't it
Yes.
possible that it'd be significantly different if they were receiving proper health care for these?
So this is a very good point. Yeah, you are absolutely right. Like we cannot compare two countries. So that's why so far we have taken care of 10 patients, and we have like 80% survivability, not 80% mortality. So which is almost opposite of what is happening in West Africa.
But isn't that skewed a little, the doctor? Because the patients that finally went to the hospital, okay, the first guy in Dallas was very sick when he got there. The guy from Sierra Leone that just passed away, by the time he got to Nebraska Hospital, he was extremely sick. So it wasn't like the United States' fault that he passed away.
No, I'm not.
He was later stage in the disease.
No, I'm not faulting anybody.
No, but I'm just saying, it seems to me that if you get proper care early on, your survivability rate is way higher.
You're
Definitely,
absolutely
like if we give supportive care and diagnose patients early, the chances of survivability are like extremely better than when they are diagnosed in later stages. Unfortunately, this has happened to the first patient which was diagnosed in the United States, Liberian citizen. So that was unfortunate. So he was very sick by the time he was admitted. And the second case, which the physician who died recently was also very sick. So you're right. So, but look at this, the expenditure on healthcare. So how are we going to compare this? Guinea, Liberia, Sierra Leone. So per capita expenditure on their health is less than $100, and we are spending $4,000. So there is a difference at ground level, what care they are going to get in those countries. So that's why they have such a high case fatality rate from these viruses. It's not that this virus is going to kill you. This is because they cannot get better care in those countries. So, and I was talking about the attributes of population. That is different from what has happened in past. Initial, like in the old outbreaks, infection will happen in a remote village, and never affected the bigger cities. So this is the first time the bigger cities or their capital cities were involved. they do not have any, I said, not even we, they do not have any good infrastructure for public health and treatment. People, they do not have knowledge about the disease, and they have a lot of distrust for the foreigners and for their own governments. And they do not want to seek Western medications. They rely more on the witchcraft and other local remedies rather than going to a healthcare facility. And some of their rituals, like getting in close contact with a dead body, that is like we know that dead body has millions of viruses, even greater than person who is sick. So they are doing that. So that also poses a risk factor. And probably there is a delayed international response to this outbreak. So anyways, now United States and Center for Disease Control, this is one of the largest international outbreak response by CDC. They have over 230 staffs on ground in these countries and at the airports where we are doing screening for incoming passengers. All the persons who are leaving these countries, and like initially they were Liberia, Sierra Leone, Guinea. Since yesterday, they have started doing exit and entry interview for the Mali, anyone traveling from Mali. So what are these exit screenings and next slide. So all travelers who are from these countries, they have to have their temperatures checked, answer a few questions regarding exposure, and they are visually assessed for any signs of potential illness. If they have any of these, they are further assessed for the disease, and based on that assessment, they are either allowed to travel or they are not allowed to travel on commercial flights out of that country, and they are referred to their respective health departments. And once anybody from these 4 countries, they arrive in the United States, the Custom and Border Patrol, they are handing over, like as soon as they enter, they are accepted into United States. They are given a Ebola kit, which has information about Ebola, what are the symptoms. It has an electronic thermometer within that kit. And after they are admitted, they have to answer questions to determine potential risk. They have their temperature checked, and they are observed for any symptoms of Ebola. If they have any of these, they are escorted to the CDC personnel, who will then assess them thoroughly and then decide based upon their symptoms or their presentations whether they can continue to travel without any restrictions, or if they are sick, they are taken to the hospital for evaluation, testing, and treatment. If they do not have any of those, they are referred to their local health department for active monitoring. And if there are any questions regarding the Ebola disease per se, so New York Health Department has a 1-800 toll-free number. We can call on this number from Monday to Friday, 8:30 to 12:30. This is just for public information. This is not, this line is not to be used if somebody is showing symptoms. They have to call 911 or their healthcare provider. So that is.
So anybody can call that number?
Yeah, that's New York State Health Line.
For the public?
For the public. Anybody can call if they have any questions regarding Ebola.
It still does not answer what was the difference between 1999 and 2014 that caused this explosion.
So, Dr. Bajwa, so the virus itself, so far the data we have, the virus is not different from what it was in 1976.
So there is no mutation or anything?
There could be minor variations, but this is not a new virus.
Okay.
Okay? And the attribute of a patient population has changed. Like in 76, probably people, they were not traveling what we are doing. Now the international borders, the borders are porous, and these, all the 3 affected countries, they do not have a very stable governments, they do not have a great infrastructure. So that's why it was so hard to control this infection this time, and this spilled out to the rest of the country.
I'm also curious about one other thing. This first patient who died, the Liberian
Liberian gentleman.
The two nurses got infected, but his entire family, nobody got infected, even though they were close contact. Was
So-
isolated from the family by the time he got infected?
So once you have symptoms, like how much time you spend with that symptomatic patient. So when we take care of patients in hospital, like especially the nursing staff, like they are with the patient all the time. They are taking care of the sick patient who is actively vomiting, having hemorrhage, cleaning everything. So they are at more risk than like rest of the general public.
You're at higher exposure.
Right, the amount of exposure.
Correct me if I'm wrong. I was also under the impression that in that case they did hemodialysis, which they don't usually do. Am I right or wrong on that?
So that's an ethical thing, like how far you want to go
No,
with.
but in that case, since we brought the point about those two nurses being exposed, is that the reason that they were doing hemodialysis and exposure was more as
So
compared to regular care?
if you are going to get in touch with the blood, so yes, you are at risk. But if we are taking all precautions, it shouldn't be that much risk. So it's not that they got dialysis, that's why they got disease. The question is whether they were using the personal protective equipment. If they were using, were they following all the recommendations by CDC? Because that is very important. Like we do use gowns, gloves, masks. How do we use it? That is important. And that is one of the stress, like one of the main points to be stressed by the health department and CDC, that all hospitals should train and retrain their staff how to use all this equipment.
One of the things they found was they were using goggles instead of a full face mask. So they would put their hands up to adjust the goggles and
The goggles
So-
would steam up. Your natural reaction is just, oh, let me adjust this. And what you did is you brought your contaminated hands to your mucous membrane areas around your eyes, nose, and mouth.
That's
So-
what firemen taught me too.
Well, I'm in charge of our response to an Ebola outbreak. I worked on this extensively, believe me.
Nice. Glad you're here. So,
Thank you.
thank you.
Thank you.
The disease is so new, we're very fortunate. We have Dr. Bajwa and Dr. Chanda, and they're asking questions that, no question is a bad question tonight, very frankly. And now to carry on, Dr. Cumbo, the first time I've met him this evening. He's the infection disease specialist at Mount St. Mary's. He served his residency in internal medicine at Johns Hopkins University and Sinai Hospital in Maryland. Completed infection disease fellowship at the State University of New York, Buffalo. Dr. Cumbo, of course, is board certified infectious disease and internal medicine, and we're glad you're with us tonight. Feel free to answer any questions. Maybe you'll disagree with Dr. Bajwa. I don't know, but maybe some of the questions that were asked, jump right in, okay?
Usually have to bring the microphone down. My task tonight is to talk about our local hospitals and our response to, well, basically what we're doing to prepare for any problems and what we do when a patient is actually admitted. So I agree with everything that Dr. Bajwa talked about. It's comforting to know that there are data out there that show that the disease is not really that transmissible early in the incubation period, and even so, even later in the incubation period too. That's good. Our biggest concern, and I know that Rajinder feels the same way, our biggest concern, besides the patient, is the protection of our healthcare workers and our first responders. I can speak to the healthcare workers, especially our nurses, because they're going to be dealing with the brunt of the possible exposures in the hospital. So not to belay or talk about everything in great detail, but we at our hospital, and I know you at your hospital, have been through a number of drills, and there are several criteria out there from the CDC and the New York State Department of Health that have helped us along the way develop a response, an appropriate response to somebody coming into the hospital. Now, that's changed over time, and unfortunately, that's the way it's going to be, probably for a little while still, because we're not used to dealing with this disease. Now, we've had other scares in the recent past, most notably, I'm sure everybody remembers SARS, which is much more contagious, and it still worries me more than something like this. But it's not the first time that we dealt with any of this, and it was before my time, when my dad was practicing infectious disease, when HIV first came out. Everybody was scared of that too. Nobody understood how that was transmitted or what to do. So this is not something that's unique. This isn't a really scary pathogen that's coming from outer space and going to kill all of us. It's not the way that it works. But it does elicit some fear in the general public, and it elicits fear in us as well, especially the people that are dealing with this most intently or most evasively. So, in a nutshell, if somebody comes into the hospital, so let's say somebody calls 911 and is brought into our emergency room, there are criteria, there are protocols in place. We actually have separate rooms where we will bring somebody. We have ways of decontaminating them in the place where the patient's dropped off the ambulance, or if the patient comes in and walks in the door and says, hey, I've just been to Africa, I feel awful, I'm spitting up blood. We have ways of getting them back into an isolated room very quickly. Now, the way New York State has set this up is that patients who are suspicious, or we're suspicious that they could potentially have an infection with Ebola virus, we will put them into isolation. And in our hospital, we're putting them into the ICU, and we actually have ways of transporting them from the emergency room into the ICU, and we're trying to minimize contact throughout the hospital. And then they will remain in the ICU until they can be ruled out via PCR testing. And Dr. Bajwa spoke of that. That's a blood test. What we have to do is take some blood from the patient, and then that blood is transported all the way to Albany. So minimum of 5 to 6 hours, depending on how you're driving. And then the PCR testing usually takes about 5 or 6 hours to do. So bare minimum, we're looking at 10 to 12 hours before we're going to get a response. That's best case scenario. So what we need to do in our local hospitals is make sure that we can isolate affected patients or potentially affected patients and make sure nobody else gets sick while we're waiting for these test results to come back. If somebody's actually diagnosed with the disease, then our plan is to move them into these Ebola hospitals, or hospitals that have been designated by the governor to be these Ebola centers. Originally, our area, it was just going to be Strong Memorial, but now it's actually ECMC and Children's, if I have that correct. But that's only if somebody's actually diagnosed with the virus. So our two little community hospitals in this area, we have to have the ability to keep these people in isolation and not get anybody sick. Now, we've had 3 drills so far because we're trying to work out the kinks. They've all been successful. We've learned something from each one. There haven't been any major problems with any of these drills. But each time we do them, we find little things that we could do better. We just had another one today, transferring a patient from the emergency room to the ICU. The 2 drills that we've had at Mount St. Mary's, and I'm sure you've done the same thing, they've been unannounced drills too. So somebody actually comes in. Our first one, we had one of our employees that was relatively new come in, sit in the car for a little while with the heater on, get all sweaty, and go into the emergency room. And we were very happy that everything worked out the way it was supposed to work.
Did they beat him up afterwards?
What's that?
Did they beat him up afterwards?
No, seriously. I don't know if she's welcome on lunch day, but no, everything worked out okay. What we're dealing with right now, and again, it's going well, but we're trying to make sure that our nurses are. That's my biggest fears for our nurses. Are comfortable in these spacesuits that they wear. Spacesuits is the wrong word. They're not wearing the things that you normally see in the movie, but they have a lot of protective gear. So they have a mask. It's called an N95 mask, which is a mask that we use for tuberculosis and other things. So as you breathe through it, very, very, very small things can't get through the pores of this mask. They're difficult to wear. And as we learned from Texas, we have their face covered with a mask too. We also have their neck covered. They're wearing a gown. They're wearing these high booties that come up to here. A surgical gown, or one of these wraps that they wear, a head net, and I can't remember what. 2 sets of gloves, a long glove and a short glove. And putting these things on and taking these things off takes about 15 minutes. So we're trying to make sure that everybody's comfortable with this, and we can get them off not, because it may be that the nurses that were exposed in Texas Presbyterian were exposed when they were doffing or taking off of the equipment. There may have been some breaches, they may have gotten it on their skin, or they may have gotten it on their neck, or they may have adjusted their goggles. In all of these things, in a highly infectious patient, all of these, you can get virus particles on you pretty easily. Yes, please.
What about medics? Like if someone called 911 and someone went to someone's house, would they be prepared to?
I could probably answer
I would
that,
appreciate
Doctor.
it.
I'm the training chief of the Niagara Falls Fire Department, and I was tasked to come up with a program. In fact, the fire chief and I are the ones, there's supposed to be 2 representatives from every department that are registered with the New York State Department of Health. We've already done that. It all starts with dispatch, okay? What happens is this. The Ebola virus is very, very similar to the flu, okay, in presenting problems. Fever of 101 or higher, you have all these flu-like symptoms. You don't know if it's flu, you don't know if it's Ebola. So what we trained our dispatchers to do is, okay, you have a temperature of 101 or higher, okay? You have flu-like symptoms. The next question is have you been outside this country for the last 21 days? If they say no, you're not out of the woods yet. I told the dispatchers to say, have you been in contact with anybody that has Ebola or treats Ebola patients? Now if they say no, it's not Ebola, okay? If they say yes, now we got to say, wait a minute, they still might have the possibility for the disease. Now, the deal is, this is what I told our guys to do. Like, the nurses wear N95 masks. The N stands for non-petroleum, 95 stands for 95% filtering. So it pretty much filters just air, viral particles can't get through. Our response is going to be full face piece with a P100, petroleum-based 100%, nothing's getting through. We're going to be in Tyvek F chemical, the weapons of mass destruction suits, gloved up. We're going to be overprotected because we don't want to get any of our people sick. But I told my guys, if that person calls 911 and they have the ability to walk, we're not going near them. I'm having the captain respond by giving an N95 mask, putting it on the outside of their door, pound on the door, walk away, say, put that mask on, sit down and wait for the ambulance to pick you up. Now it's going to give you guys in the emergency rooms time to set everything up, because if they're not that sick, there's no big hurry. And that's what I told my guys. There's no sense going through all of this protective layer upon layer upon layer if you don't need to. So just by distance alone, none of our guys are going to get sick. The person's going to be wearing an N95 mask, so now whatever they breathe out is going to be pretty much filtered. Okay, it's not going to get out because of that N95 mask, and we're going to wait for the ambulance to however they want to treat them up. But we have an initial response. It's going to be like alphabet soup. Okay, there's going to be 2 engines. There's going to be a heavy rescue. There's going to be a chief. The fire chief's going to go. I'm going to have to go. Okay, the police are going to have to be there, an ambulance crew, and an ambulance supervisor. If there is somebody with symptoms that can't walk themselves. But as far as Western New York, I just don't see it. I'm sorry. But if we do, we are ready. We know what we're going to do. And we're going to try and keep the exposure to an absolute minimum. And if the person's well enough to call on the phone and walk, they can certainly sit down on their front porch with an N95 mask on and wait for the ambulance to get everything they need to get ready. They can walk to the ambulance, sit down, we'll wrap them in sheets, and guess what? Nobody's been exposed so far.
What happens to volunteer firemen?
It's whatever protocol they have. I'm in charge of our department, so I know what our guys are going to do. What other departments do, that's on them.
Yeah, so, we're all trying to work together. We had a visit from the state, the Department of Health, and we have representatives from all departments, including the EMS. And same thing, everybody's coming up with protocols, but they're all based upon these same basic criteria. So you may wonder, why am I putting the nurses in these, T100 masks, these Tyvek suits? I put on just the stuff that the nurses are going to wear to be in these rooms. It took me forever to get it on. It took me forever to get it off, and it's very uncomfortable, very difficult. So putting on one of these hazmat suits, it's almost impossible to stay in a room and actually do your job properly. And as far as we can tell, the risk of transmission using these non-hazmat suits is, compared to a hazmat suit is twofold. So that's what we're doing. In our hospital, we're limiting our nurses to 2 to 4 hour shifts inside the room. Nobody else is going inside the room unless it's absolutely necessary. We're working with our pathology department to come up with point-of-care testing, meaning we can actually do the blood tests at the bedside for the tests that we need, so the blood doesn't have to go to the lab. Because every time you take the blood from the patient's room to the lab, it's a potential breach.
Are you saying about the PCR?
No, I wish we
CBC,
could. Wish we could. No. Just if you need a CBC,
Okay.
platelet count, that sort of thing, monitoring electrolytes.
Okay.
I saw an article in the internet. I can't remember where it was, but it was some of the doctors that were actually sick, and I think it was in kidney, and they showed how much electrolyte solution they used, and they both recovered from this. It was pretty interesting, but it was liters and liters. It was cholera-like liters and liters of electrolyte solution along with IV solution. So the oral rehydration solution and the IV, liters and liters every day, and that seems to be the case with this. If you can catch this early on and actually make sure
But
this
that's
stays
the key, if you catch it early
gotta catch it
on,
early.
that is the main key.
that is the main key.
Yeah. If you reach that point that you are above,
Organ failure.
then you're done.
Yeah, once you start going into organ failure, it's
You're done.
chances are you're probably not going to come out. But just to put it in perspective too, as I know you guys know, many of you probably know this too, the risk of catching influenza, which I'm personally a little bit more scared of,
Sure.
so much more. And the risk of having a potential problem from the influenza, such as a bacterial superinfection, a pneumonia, this is what kills people around here. Thousands and thousands of people around the country every year.
Exactly.
So just to kind of put this in perspective, if you're not, and I'm not trying to be paternalistic here, but if you're not worried about getting a flu shot, there's certainly, these two things are not even comparable, okay, as far as risk to you. So certainly go out there and get flu. Do it for us. If you're going to be around, if you know anybody that's going to be around, do it for us, please. If you're going to be around anybody that's traveled to West Africa, if you're going to be going to West Africa, or you're going to be around people that are treating, or you know anybody that is, please encourage them to get their influenza shot. Reason being, exactly what you were saying. In the early stages of the disease, the two diseases are indistinguishable. So I don't want to get a phone call at 2 o'clock in the morning from the emergency room doctor saying, I got this guy, he was just in West Africa, he's got a temperature of 101, because then we got to do all of this stuff. It's really time consuming, we panic everybody, and if it turns out it's something simple like influenza, that person's probably going to get over it. It's, if we could just cut out one of those cases, it would be a big, big deal. So that's just my after school special.
Doctor, we keep hearing about chlorine. Isn't that what they wash themselves with?
And the chlorine?
Chlorine?
Yeah, that's just bleach. So there's two ways that we're using bleach. One is, as people are taking off their gowns, they actually get a point down with bleach, where these chlorine wipes, over as people take off layers and layers of this, and they take off some of their gloves. And the other thing that we do is we basically sterilize the entire room. So the virus will die. The virus is not a very healthy virus. It doesn't like being outside of a person or a reservoir. It will die pretty quickly on contact. And if you expose it to bleach, it'll draw over. So this virus doesn't want to be here. It wants to be in the fruit bats. And if you try to think like a virus, I know it seems a little bit perverse, but if you think like a virus, it wants to be somewhere where it's going to be able to live, not cause any trouble, make sure the host doesn't die, because when the host dies, it dies. And so it wants to be inside its own ecosystem. And the way these things get spread out is because that ecosystem is somehow violated. And then it gets put into a new environment. Now, when it gets into a human, it's like an amusement park, because our bodies don't recognize the virus very quickly. We don't have antibodies, so the virus replicates like kids with sugar. And before you know it, it ends up killing the host. And I don't mean to speak of people like that, but just to put in mind the mindset of what the virus is thinking. And then the virus dies. It doesn't want to be here. And in the same token, once you actually halt the spread of this from person to person, and that's why there's this big international response now, because if you can actually halt the spread, the virus will start dying out very quickly, because it doesn't do well outside of its own native environment, if that makes sense. What else? tell you.
Don't go way too far, because now we have somebody from the health department. Going to talk history a few minutes. Elaine Roman is Director of Planning and Emergency Preparedness at the Niagara County Health Department. She's worked with the County Health Department in health for 24 years. She holds a Bachelor of Science degree in nursing from the State University of Buffalo and a Master's of Arts degree in Security Studies from the Naval Postgraduate School Center for Homeland Defense and Security. She has been the Health Department's Public Information Officer since 1996 and served her primary role as Director of the Division of Planning and Emergency Preparedness since 2002. And Elaine, I guess you can tell us exactly what these guys said. Here, have it. Power. Thank you. Glad you came from the fire department today, too. Okay.
Well, thank you. I wanted to be here to see what, what the latest is, because it keeps changing.
Yeah, this is a community affair.
Oh, absolutely.
Absolutely. It's all the more important, we are near the border.
Right, and it's, I tell my guys always,
Yeah.
full PPE, BSI, body substance isolation, try not to get in.
Are there some nurses here besides, just for real show of hands? Are there some nurses here in the council group?
When you're done.
Any other doctors that I missed?
Wash your hands.
Exactly.
Wash your hands.
Wash.
Yeah, I had to do all 4 shifts. I told them, I said, listen, guys, the flu kills.
You need the microphone, you okay?
Exactly.
This is not,
Nothing.
this is more deadly, but the flu's more variable.
Yeah.
So we got to get, like all calls, wash your hands.
The chances of us seeing him in
Very little.
no international.
I've been asked to just talk about health department roles and responsibilities, and I guess I
Is
just
everybody here?
wanted to say,
Yeah, we can.
you know, we are like connectors, but all of us in this room and all of the people we work with are the community. All of our hospitals, our emergency management officials, our first responders, our police, our ambulance drivers, our paramedics, we are all the community, including all of those people that are here today and people that are out working at their work sites. And we all work together. I wanted to say that our most primary concern in the health department is protecting the health of the community. We are population health, so unlike our doctors and our nurses who are in the hospitals, they're doing one-on-one service treatment. But at the health department, our concern is the entire population. So it's really critical that we have strong communications with our hospitals. And we share a lot of our protocols. In any circumstance like this, it's the duty of our public health director or our chief public health officer to make sure that the wheels are turning and that we're all doing everything that we need to do, but he can't do it alone. So it involves all of the partnerships of everybody, cooperation, coordination, and the collaboration of all of our agencies and people. These are some of the strategies that we have as health departments and with our partnerships. The most important factor in any kind of a public health threat is seamless communications. And we saw in the Dallas incident that there was a breakdown of communications. There was a breakdown of communications when Mr. Duncan came in. A nurse identified that he might have travel history. It didn't get transferred. There was a breakdown of communications in the entire system. And we've learned so much from that. We've learned that communications in any kind of emergency is critical. Prompt identification and treatment is the other thing that we have to We rely on monitoring our communities and identifying people who may be at risk or may put the public at risk. And the faster we can follow up, the better the outcome. Oops. These are some of the strategies of the health department. Public information is very important. We've been out in the community like we are tonight. Of course, the doctors gave the overview of Ebola and what really puts you at risk. But that public information is so important that the community is not afraid of what is out there, and that they know that everybody is working together. We're all on the same page, and that we're working to prevent the virus from entering our community. And if it does enter our community, we can contain it, identify, contain, and control it immediately, and give compassionate care. These are some of the things that we do. We provide guidance for our hospitals. We work with our New York State Department of Health, and the CDC, and we are continuously on conference calls with our hospitals and these entities. Isolation and quarantine. It's the duty of the doctors to isolate a case if it has the disease or it is a suspect case, but it's also the duty of the public health officer to do the follow-up and institute quarantine on contacts of people. So if somebody has come in contact with a real case, making sure that person is also monitored very closely. And we're doing that in a variety of settings. These are some of our partners. This is Customs and Border Protection. Our health department has met with them, and I know the doctor was talking about some of how they follow up at the border. Our nurses right now respond to the border if they have somebody who has a travel history and they're concerned. And we assist with taking the travel history and monitoring for the temperature, and then a decision is made. The CDC is called, and the state health department, and a decision is made whether to allow the person to cross the border into our country, or if that person needs to be contained immediately in monitoring. And there's a variety of different ways that we monitor people. We also have been working very closely with our first responder agencies. We have dedicated ambulance company. Should we identify somebody that might have signs and symptoms, that would come into our clinic, a dedicated ambulance, and a plan with our hospitals. And we're all on the same page what ambulance company we use. Our dispatch is trained that when a person calls 911, or if an ambulance company calls the dispatch, they are trained to collect a travel history, so that our first responders are not put at risk. Before they even report to a house, they've got a travel history taken so that they're not put at risk, so that they have a chance to prepare. And then the first responders know to notify the hospital if they're going to be transporting, so that the hospital has time to prepare and get ready. And some of the hospitals have people that are right out front, so that people who come in from the community can't come in and contaminate the whole hospital. There's a whole system in place so that that person is taken to a special area.
Are our hospitals the same way? Both our hospitals do the same thing?
All of our hospitals do everything the same way, so that the health department is notified immediately, and then a decision is made if that person is at risk for having signs or symptoms of Ebola. And then before that transport takes place, the hospitals are notified. The hospitals gear up, they get ready, to take that patient to, the ambulance goes to a specialized area, and then when that patient is delivered, the patient is delivered to a specialized area. So there's containment, protection the entire way, so that the people that are in the emergency department waiting their turns as patients are never exposed to that person who comes in that may be a suspect or a person under investigation.
Elaine, if I may, and I don't think I'm wrong, I've talked to both St. Mary's and Memorial. Memorial has rooms 11 and 12 designated that you can't, you're going to take the person, if there's one in Niagara Falls, and they're going to wait outside. It's on the Ferry Avenue side of the building, and they're going to go in for a separate entrance, and they're going to stay in rooms 11 and 12. St. Mary's is set up for rooms 7 and 8, and they're not going to go in the general emergency room. That's their isolation rooms.
They don't go, they.
So this way, like she's saying, everybody is, there's minimal exposure to hospital and to other people in the ER.
One of the things all of us are doing too is that we're all testing our plans and exercising. All of us. The hospitals have been very, very diligent. It's been very hard for them to continually do this, but we are doing the same thing in our health department also. We have clinics, they're called Article 28 clinics, and we are also doing the same thing, having a pretend patient come in or a suspect person. We have to be able, our staff has to be able to identify that this person, asking the right questions. That involves also including our security in this, just like hospitals involve their security. It's not just the doctors and nurses, it's entire organizations and the entire county that is working together of these organizations to make sure that we ask the right questions, we're able to do the identification. We look at clusters of information and then we process it. And we don't process alone. We work together. We take other people on board with us, like our New York State Department of Health. Our hospitals work with our health department, New York State Department of Health. Our law enforcement is involved. So every one of our agencies is in on how we're planning and is practicing and training along with us and knows the right questions to ask and what the follow-up is. Consistent guidance is really important. We know that New York State Department of Health and CDC have been pushing down tons of guidance. We are pushing it also to our hospitals and to our EMS. It's going through our EMS councils and through our local emergency planning committees and to clinics, to our Niagara County Jail. There are a lot of places where you wouldn't think maybe something could show up. And with our border people.
Does the health department have access to the travel records of people?
To what?
Does the health department have access to travel records of people?
Yes, that's the other thing.
The reason I'm asking is at the border they ask you, like the airport. But if I'm a traveler and I know I'm going to be asked these questions and I'm going to be quarantined, I have every intention of not giving the proper information.
This is how it works. We get a list sent to the New York State Department of Health. If there is a traveler coming from a country of interest, we get that list sent to us and then we review it. And so that we have it, we can check against it if we have an incident at the border. But we do know that we have, even in Niagara County, we have many undocumented people. People do not always take traditional means to get into our country. So, but it always helps to have all of these mechanisms in place by land, by sea, by rail, by air, in place so that we can catch as many people as we can to prevent this from entering our country. So far we've only had one incident at our border, just one. And it ended up not being a person of concern in the end.
Do the hospitals, they all use on the same technology center, they get the information at the same time?
We would pass it down to the hospitals. If somebody came into our country, there was a person of concern, that person would be monitored first, because they're not going to get in symptomatic. a determination would need to be made, the level of risk. Just like Doctor was talking about, the level of risk, determining how we're going to monitor. If it's a very low-risk person, we're monitoring a little more stringently in New York State than the CDC recommends. So if it's a low-risk person, we will have them self-monitoring the temperature, but we also will be required to make 2 unannounced visits to the person will be quarantined in the home. But that doesn't mean that if that person comes here from another country and is under a quarantine, a voluntary quarantine in a home with relatives, that doesn't mean the relatives in the home would be quarantined and monitored. Only if that person develops signs and symptoms. But there are measures in place. For example, that person would stay in a separate room whenever possible, whenever feasible. But being very closely monitored for the onset of any signs and symptoms. This is, I was talking about, it's really important how we share not only communications and information, but how we share resources. This is our hazmat person, training manager, Mark Hain. And we are outfitted, and we were trained and outfitted through our local hazmat team in Niagara County. We were able to order our personal protective equipment through the Department of Homeland Security because we know that our funding is very low for public health departments. And we do also have a little bit of a stockpile just in case, as well as memoranda of understanding. And, you know, if something were to happen, which is not likely to happen, we do have a mutual aid plan through the fire service so that if somebody were to run out of PPE or run out of personnel, we do have a cross-county agreement to help each other out. As I said, our main goal is the preservation of our community. We have very active surveillance systems. I wanted to say as a health department, we do emergency room syndromic surveillance every day. We collect the information from the hospitals. They actually conduct the emergency room syndromic surveillance. And that is to look for any kind of spikes or peaks of abnormal kind of illnesses that come in through the emergency department. We are also doing surveillance out in the community, and we do the contact investigations of people who might be exposed. So, for example, if our hospitals do take a case in, we are responsible for doing the follow-up of anybody who may have come in contact with the case. And those people are separated from the community and quarantined. So we use quarantine for people who are not sick, but may have been exposed to someone who had an illness, who had the Ebola. Now, what do we do about people who are working directly with them? Under some circumstances, if there may have been a breach in the personal protective equipment, or somebody feels that they may have had some kind of exposure, the healthcare worker may be put into what we call work quarantine. So work quarantine would mean that that person could go to work, but leave work and go home after the care of that Ebola patient. As long as public transportation wasn't taken, the person could still go home to the own home and still be monitored for temperature. So this is if there's some kind of, if they feel there might be some kind of a breach where there might be an exposure to a person that was having Ebola in the hospital. And Petra, did you have a question about that? And they did that with SARS, so that the people are limited, it's called controlled travel. They're limited to where they can travel. And one thing the public doesn't know, I don't know if anybody mentioned it, but healthcare workers who are assigned to work with an Ebola patient or a suspect, they're dedicated to that patient. The equipment is dedicated, and the healthcare workers are not traveling throughout the hospitals caring for other people. So that in itself is almost like a little work quarantine right there. We're making sure we control. Some of the things that are under development are, there are some vaccines that are in compassionate use trial now in Sierra Leone. Some of the healthcare workers and the doctors have been vaccinated, and they're continuing to care for Ebola patients, but of course, using the same precautions that are recommended, no skin exposure, completely covered. And we're hoping that this vaccine will be effective and will also help contain the outbreak in West Africa, because that is the primary issue, containing and controlling West Africa so that it doesn't spread, because in other cases it was self-limited. However, if it should come here and we should have an outbreak, we would be implementing mass vaccination if we were asked to. But who would be first would be the persons on the front lines caring for Ebola patients, and for our first responders that would be called to care for patients. That is, if it would ever get to that point, which we're pretty sure it never will. But that's one of our functions as a health department. And of course, it's the baby flu there. Are there any questions?
I didn't get out at 7:30, it's right 7:30 right now. Here, very good. One thing before, oh, I'm sorry, yes, sir.
Forgive me, I got in late. I've got one question. Where does Ebola reside between outbreaks?
I'm sorry?
Where does Ebola reside between outbreaks?
The fruit bats are the reservoir. Humans and non-human primates are what we call the hosts. So they can live in us, but the reservoir where they live, like the doctor said, where they prefer to live are these little fruit bats. So sometimes things happen, they spill over, like those cultures there, they're cute, they play with them like pets, and they eat them as food. So this is how they spilled over into the human population and into the primate. Their droppings, etc., spilled over into, like the monkeys and the gorillas and the
In
primates.
these countries, don't they eat the primates too, the monkeys?
Yes, they do.
And the
Would
bats.
that be a source of spread too?
That's why they're trying to limit, and there's also a trade in bushmeat. They
Exactly.
have it at the markets, people travel. They have different conveyances now. They don't just travel by foot, and we have contraband. And it's another thing, at our border. They're always looking, the USDA is at our border, they're always looking for animal contraband. Like during SARS and during the H5N1. They were bringing chickens and things for H5N1, we knew that poultry was an issue. So that's another control that's in place.
Is there anybody from the media here? I just wondered. That's one of our reasons. We really should have the media here, and all the things you said should really get out to the public, because you said communication is the key.
Well, this is one thing that both Patrick and I do, is that we publish on Facebook. We have a Facebook at Niagara County Department of Health. We do post information on there, but we do routinely send out press releases. Our hospitals worked with our health department, and we put together a press release that we sent out to the community with key points. And then the media did come and talk, and the media was at Niagara Falls Memorial. I don't know about that, did you have them? I know that we put our heads together, and Patrick really initiated that we should do this, and our public health director called your hospital CO. So we are working together with the media.
Thank you very, very much. I just want to say one thing about this whole process of our forums and our communications. If you have any ideas about programs that you think the library would be a good setting to have a forum and bring people here, please talk to Michelle or any person on the trustees, because we want to do this once every 6 or 8 weeks and bring a community concern right here at the library and talk about it today. And I just want to thank all three of you for being here and thank everybody for coming, because I think what they heard tonight, community also do at the same time.
There's one more thing, and if I didn't mention it, we have babies out in the community. There's a pertussis outbreak, whooping cough. This is a vaccine preventable disease, as well as influenza. Our health department can't stress enough the importance of all people getting their flu shots, all ages. Make sure your babies 6 months and up get it, adults, but we have an adult vaccine for pertussis. Pertussis kills babies. Sudden infant death syndrome, we had Chuck Schumer talking about that, and we had people talking, we need more measures and controls, see why these babies died. We don't want them to die, and then you have to try to do an autopsy later and see what killed them. We want people to get vaccinated for pertussis because little infants often will just die in their sleep, and you know what it is? It's pertussis. They don't have a cough mechanism. So please spread the word. Adults, if they need a tetanus shot, please get the Tdap. It has the pertussis in it to prevent whooping cough. So if you haven't had a tetanus shot in 10 years, please talk to your doctor about getting the Tdap, the pertussis-containing vaccine. Get your flu shots. 36,000 people a year in the United States die. Some of them are healthcare workers. We want everybody to please get your flu shots. These are the things that we should be afraid of. Pneumococcal pneumonia is another one. These are the things we want the public to be aware of.
Thank you very,
so
very much.
much.
Thank you all for coming.
Take that with me?